Session 2A, Rarely Discussed Hepatology. This has two parts. First is a panel discussion, followed by talks. For the panel discussion, may I please invite Dr. Ajay Kumar, who is the moderator. He is the chair and head of BLK Liver and Digestive Diseases Institute of New Delhi. He is also the chairman, Pan-Max Gastroenterology and Hepatology, New Delhi. And for this, may I request the panelists to please take their seats. Dr. Narendra Chaudhary, Dr. Amit Mando, Dr. Charles Panaku, Dr. Vineet Shah. Thank you.
You have a pointer? It's okay. Thank you, Chairman, and thank you, Akash, for putting me in this difficult situation. And, I have a disclosure to make that I am no expert in this area, and but I'll try to get the best out of the experts sitting on that side. One of the panelists is missing. Right? Okay. Okay. Anyhow, well, friends, we all as clinicians deal with the patients with a drug-induced liver injury. We look at the drug, but very rarely we get into the understanding of the basics of the drug-to-drug interactions. Conceptually, you can have pharmacodynamic drug interactions, which can be both desired and undesired. Like you use two laxatives, say lactulose, mycophenolate, in the same patient, you can have diarrhea. Or you can have a desired combination of antibiotics combination in the treatment of Helicobacter pylori. But what interests the clinicians more is pharmacokinetic drug interactions. And that means what body does to the drug in contrast to what drug does to the body in the pharmacodynamic. And here there are four elements, out of which metabolism and elimination play the key role. So pharmacokinetic interactions are of particular importance to us, as GI experts and the liver together play arguably the largest role of any organ system in the absorption, metabolism, and excretion of almost all medications. Now let's look at the liver metabolism per se. The different phases. In the phase 1 is a hydrolysis, oxidation, reduction, and methylation, while phase 2 is the conjugation or glucuronidation and sulfate conjugation, and phase 3 comes the excretion with the various ABC acid family enzymes involved in that. Just to give an idea of this, that you have unconjugated bilirubin getting into the hepatocyte, getting conjugated, and some of them will be going to the bile, and other will reflux back to go back to the rest of the hepatocytes and to get handled there. And today what we will be looking at more on the conjugation and the elimination part. Just give a few examples of that. And for metabolism, that is the conjugation part, the most important is the cytochrome P, that is CYP450, which has 6 predominant isoenzymes. And I would like you to focus that all of these, out of all the 6, CYP3A4 is the 40% of the liver isoenzyme and causes metabolism of 60% of medications. And while CYP2E1 is also important, and we'll talk about, look at it in the next case presentation. And when you come on to the excretion, the permeability glycoprotein PGP is a drug transporter and has become important, and we'll look at how does it play in a clinical situation. So I've taken some few examples of each, that is induction of the cytochrome P or inhibition or the induction of PGP, and handle that. Here's a case capsule. 55 years male under follow-up for MSLD, no advanced fibrosis. develops pulmonary tuberculosis and is on anti-tubercular treatment for 4 months and currently on HR. Complains of loss of appetite and low-grade fever for about 2 weeks and is diagnosed as acute severe hepatitis on the basis of investigations, and which is confirmed on the investigations. But naturally, when you look at acute hepatitis, you work for all the viral parameters, you work at the autoimmune, but all were found to be negative. But look at, is it a drug-induced? But drugs have been going on for 4 months. And there's been no significant history here. And there has been some use of paracetamol, but it doesn't give any history. Within 2 days of the admission, patient goes into encephalopathy. Now, let me come to Dr. Narendra or Dr. Vineet, any one of the two can take up. What is your next choice?
So it is acute liver failure, non-viral, probably not related to ETT. So further workup and drugs, complementary medicines like that.
So that's where you go back to the patient, put somebody on duty to sit down with the family attendants, patient is in encephalopathy, and take the detailed history and history review. Patient had a fall while running around a week before the onset of symptoms and took 2 to 3 grams per day of PCM due to pain, attended 2 cocktail parties during that week. And that was enough to make us think what it is. And then also, when the patient entered the triage, patient received PCM in ICU for the first 2 days due to fever. So now, if you look at the paracetamol-induced liver injury, it is all we all know that is metabolized partly by CYP2E1 and to the hepatotoxic metabolite, and that is NAPQI. And this CYP, now induction, I said the example of induction of CYP2EI is an alcohol, patient gave a history of that, and also it is induced by the anti-tubercular agents. The same anti-tubercular isoniazid which he has been taking for 4 months, now that comes into play, and that explains the worsening, and that actually helps us in diagnosing, and rather than going for any modern things or any other further interventions, and all the drugs were withheld. And this is just to diagrammatically to show that these are the 2 mechanisms by UGT and SULT, and this goes, this is normal, but when you have activation of CYP2E1, you have isoniazid, ethanol to substantiate that, and then you have NAPQI, and that's what leads on to hepatotoxicity. And this is a prime example of the case to explain us. So, any of the panelists, what is the message from this case? I mean,
Sir. Yeah, so always take a detailed history, go back to the drugs, because here initially we would have thought ATT-induced hepatitis because INS can produce a idiosyncratic drug reaction even later. But going back to history, it looks like patient had a staggered dose of paracetamol, and with a combination of enzyme inhibitors that has led to the hepatitis and the acute liver failure. So always take a detailed history and from the patient as well as the bystanders, and that would be the take-home message here.
see, it's not possible for all of us to remember all the drug interactions. But whenever you have unexplained clinical picture, put a good, smart resident on duty to sit down with the family and to take out all the old prescriptions and everything and try to sort that, and quite often you may find. And Dr. Narendra, can you give some more examples of harmful drug interactions involving induction of CYP?
So combination of isoniazid and rifampicin is more toxic than either drug alone. Rifampicin causes rejection in post-transplant patients because tacrolimus levels are decreased significantly. Rifampicin, phenytoin, these decrease effect of sofosbuvir-based regime. So these are some of the examples, and these are common drugs that we can miss.
Anything else? Anybody? Any other panelists? We go to the second case then.
Yeah. So, sir,
Yes, Vineet.
better is now we all have Android phones. There are very good drug interaction apps available, especially Medscape and Hippocrates. So even if we are finding unusual drugs in the prescription of a patient with liver issues, better to just put the drugs and see the interactions, I think. So as you rightly told, it is not possible to remember, but
Right.
it can be done very easily.
So let's go into the second example of induction of PGP. We had a patient of a retroviral disease on controlled HIV RNA, low normal CD4, and patient has been on tenofovir and ritonavir and ABC, detected HCV. Patient started, as I already mentioned, on SOFO and Velpeta, and LFTs were normal at 4 weeks. But patient comes back in 12 weeks with raised transaminases, with a normal bilirubin and HCV RNA shooting up. Now, patient has been compliant with the medicines and procured from a reputed source, and no change in antiretroviral medications during this time. And whatever the clinical history was, that no slips in history and no new medications were added. What next? Yes, any of the panelists taking up this question?
I think again we will have to look at the possible drug interactions, because we know that HIV drugs, especially the class of protease inhibitors and the directly acting antivirals, there are definite drug-to-drug interactions. So I think they could reduce the efficacy and could be one of the reasons why the patient has not achieved SVR.
So, in spite of the fact the careful history did not suggest anything, but then a smart resident asked the family to get all the medications. Patient was taking a combination which is usually not available in the market as it is. It's not supposed to be combined, but by a local company, because it was a cheaper drug, he was given a combination of this. And this is a PGP inducer, not recommended with the SOFO and Valpa combination. It decreases the levels, and if that's what exactly this happened, that it decreased the levels of the anti-Hep C treatment, and patient went into a recurrence of that. So what is the message from the above case? And the message, obviously, that don't rest only on the history. Please fetch the drug files. All surprises can be in store. And that's actually going back to the same story, careful history, careful going to the prescriptions, careful going to the drug files. So examine the drug files to check the genuineness of the medicines that patient is disease. So, can you give some more examples of harmful drug interactions involving induction of PGP? Yes, doctor.
So I think PGPs is the main mechanisms of excretion of drugs. So there would be either inducers of PGP or inhibitors of PGP. So inducers would eliminate the drug faster, would reduce the efficacy, and inhibitors would increase the drug levels. And we need to understand these, and we also need to understand that a lot of these drugs which act on PGP also act on the CYP450.
Yes.
So they may be inducing the metabolism as well as...
No, I just wanted for the clinicians here to give some common example for that.
Common example, the classical one is rifampicin, which is an inducer of PGP. So the inhibitor one, the example would be verapamil or even ketoconazole, macrolide antibiotics, and they can sometimes... one of the drugs is the anticoagulation, so they can reduce the efficacy of dabigatran, especially. Also with immunosuppressants, they can reduce the efficacy of cyclosporin and tacrolimus, because they are also the substrates for PGP.
So coming to the third important ones, see, there are a number of, I said there are almost 6 isoenzymes of the CYP, but we are talking about in general that it can cause induction, drugs can cause induction, drugs can cause inhibition as CYP. Let's look at the third case. 65 years old female, transplant 5 years back on TAC 0.5 twice a day and was stable. Developed fever with loose motions, suspected typhoid. Initially, the physician, GP started on ciprofloxacin, but patient developed seizures and reached the emergency. And when they found tacrolimus levels almost 22. So what exactly happened? Yes, doctor.
So I think so there again the role of very careful history taking about which are the drugs in addition to this, because many times
Exactly. Like, let me just fill it up. The story of a revisit history. Fever when did not settle down for 3 days, then they started on azithromycin, which is actually not only a resistant. Nowadays, physicians are actually using a first-line drug for treating enteric fever in our country. And when patient finally woke up after 2 days, taking a daily pill for last, came out of the history, was taking a pill for the last 2 months, prescribed by dermatologist for white patches on skin 1 year back. And when the patient was asked to bring the medication box and see what you got, the patient was taking itraconazole in that the list of the medicine was itraconazole. And so if you look at this, we talked about 3A, 4, 5, and you look at the azole antifungals, and you look at the calcium inhibitors. I mean, this is a strong combination. It's the inhibition of that. So that's again that when you started these medicines, the drug levels which was going on stable, then they came down, became ineffective, and all become things go haywire, and patient goes into the liver dysfunction. Can anybody give us an example, important example, which in day-to-day life of drug interaction where effect of the drug is reduced by inhibition of enzymes? Here we saw an example where it increases the effect, but by where effect of drug is reduced. Yes, no.
Yeah, if you have a prodrug and that's metabolized to an active drug by the enzymes UIP. So if there's an enzyme inhibitor, then the prodrug will, the active metabolites will be reduced. And some of the examples, one is what we commonly use is tramadol. It's a prodrug, and it's converted to active hormone. And second would be losartan, antihypertensive. Again, it's converted to its active metabolite by UIP. So any enzyme inhibitors can reduce the efficacy of these drugs.
Right. Yes. Another common example, PPI
And clopidogrel.
is a very important example. We all talk about it, interaction, because clopidogrel is a prodrug and it has to be metabolized. And if you inhibit the enzyme by PPI, it is supposed to reduce the effect of clopidogrel. Of course, the randomized controlled trial published in NEJM that did not show any clinical effects implications, but theoretically, yes, it fits into that. So we are coming to the end of that, but any other comments by the panelists or by the delegates, any questions you can ask from the panelists, please, most welcome.
Yeah, so some of the common drugs that we miss, one is calcium channel blockers. So, and the antidepressants like fluoxetine. We always think of itraconazole, we always think of macrolides, we always think of rifampicin, but commonly used drugs like fluoxetine or calcium channel blockers or PPAs, all these can interact with common drugs. So we should always look at polypharmacy when we have unusual presentations.
And another important point which we need to understand in liver disease is we still don't understand at various stages of cirrhosis how these drugs are affected. So we always think of cirrhosis, but there is compensated cirrhosis, decompensated cirrhosis. As the liver pathology worsens, the hepatocyte pool is going down, there is shunting of blood. So all these mechanisms are very important and we still don't understand. Unlike in creatinine clearance, where there is a single marker. So most of the drugs, how they are affected by worsening liver disease, we still don't understand. At a molecular level, though we know the mechanism.
Anybody from the audience want to pose a question, or experts want to pose a question to them?
So I have a question. One of the very commonly used drugs in diabetes is voglibose, and it's usually given after the meals to reproduce postprandial hyperglycemia, and it inhibits the absorption of carbohydrates. So what is your take on the use of these medicines, and how does it interact with the other drugs, especially many tablets which are coated with actually carbohydrate?
I don't think we have any experience with that, and anyone in the audience who can.
What was the?
There are so many drugs which can have potential effects on, and it's not an answer, it's another question. Do we have a net-based platform or an app to see whether if you put these drugs, how they're interacting? Is there an app available?
Yeah, Medscape is a very good app, and Hippocrates. These two are very good apps where they have a drug interaction checker, and if you put the drug, then they give you the exact mechanism, which enzyme is inhibited or induced, and also what happens to the drug levels. And the good thing of app is you can put multiple drugs, so you can put 3 drugs also. So it's Medscape and Hippocrates are the two very good drug interaction apps, particularly for hepatology.
Yes, Patrick.
So I recommend Micromedics. It's free. I just showed Akash here. I think it's very good. Put in all the drugs together. It will tell you what the interactions are, which one dose should be reduced, which one has to be increased. It also gives you very interesting things which you don't know. Patient will ask, can I have this medicine with cabbage? So, you don't know. For instance, here, acetaminophen, if you give it with cabbage, decreased level of acetaminophen. So it'll tell you which food gives you a problem. Very simple and it's very cheap. So anytime I start a new drug in a patient, or if they've got some funny symptoms which I cannot explain, I go to Micromedics and find out interactions and check. It's too difficult to remember all these things. I just go to Micromedics.
See, whatever I had to sum up, I think has been summed up in one line by Patrick, that biggest battleground for drug-drug interaction is liver and GIT. This can affect both effectiveness as well as safety of the drug. And it's almost impossible for us as a clinicians to keep in touch or to be knowledgeable about at every stage about the drug interactions. In this era of polypharmacy, if you look at a prescription of some of the patients are carrying almost 10, 20, 15, 20 medicines, and it's almost impossible for us. And sometimes the trade names are different, combinations are different. It's not easy. So please fetch the clinical history, prescription, get the combination of the drugs, and then you need some tool, what Patrick told us about, to put it there and see. And do examine all prescriptions and drug files and keep in mind common culprits. And with that, I thank for the panelists and the experts for a wonderful interaction, and I hope we go home wiser with this. Thank you very much.
Thank you, sir. Thank you to the panelists for such a thought-provoking session. It was especially very useful for all the residents sitting here and fresh pass-outs like us. So, let us carry on to the second part of session 2A, rarely discussed hepatology. For this, I'd like to invite on stage our chairpersons, Dr. Malina Khanna, Dr. Dept Lahoti, Dr. Ramesh Satarkar. Please do take your seats.
Good morning, all. We'll proceed with the second session. The brainstorming, which has been going on since morning, will continue. So we have 3 topics in this session. Okay, so there's some change. Probably the first.
Yeah, there is slight change. Dr. Muthaiya's lecture has been rescheduled.
I invite Dr. Ashwani Singhal on his talk on recent advances in therapeutic of alcoholic cirrhosis, drugs, genes, and beyond.
Well, morning everyone, at the outset I would like to thank Dr. Shukla for this opportunity, and thanks the organizers and the chairpersons and the panel experts. So when this topic was assigned to me by Akash, I was thinking how I'm going to cover the management of alcohol-associated cirrhosis in 15 minutes. So at the outset, I want to make a disclosure that we will not talk about corticosteroids. I think in the last 40, 50 years, there has been not much change in how we use this medication. We'll not probably talk about liver transplantation. I'll just allude to these because more or less we have known how the liver transplantation works. So we'll focus mainly on some new therapies in this area. So with that disclosures, and here are my own disclosures, none of them is relevant to the presentation today. So if we talk about key determinants on the pathogenesis of alcohol-associated liver disease, so let's talk about the injury to the liver direct through alcohol metabolism, reactive oxygen species, and indirectly through gut-liver axis pathway activation. And then there is an interaction of alcohol with the brain, with the reward center and VTE to cause addiction pathways. And that leads to systemic and liver inflammation and cytokine response. And that determines the clinical phenotype of what you will have in an individual patient. And finally, the advanced disease is predisposed by certain host and environmental predisposing factors mentioned over here. So with that framework on pathogenesis of liver disease, let's talk about how the phenotype develops. So the early liver disease, which is fibrosis stage F0, F1, or maybe F2 with steatosis, and more advanced liver disease with the cirrhosis, compensated and then decompensated. A subset of patients develop alcohol-associated hepatitis with acute and chronic liver failure in the most severe forms. And the liver disease of the early variety may present incidental findings of steatosis and liver enzyme elevation. The cirrhosis, when it is more advanced, with varices and decompensating events. And finally, the jaundice and development of multi-organ failure, either precipitated or complicated by infections. And then alcohol use has its own phenotype, a lot of comorbidities, especially psychiatric comorbidities mentioned here. And finally, what happens to the patient can go one side, deteriorate, gets hospitalized, infections, and mortality and liver transplant. On the other side, can recompensate and recover, and mostly determined by what is patient doing in terms of alcohol use, which pathway the patient will go to. So this gives us an opportunity to talk about alcohol-targeted treatment, mostly in early disease. That's the only thing you can do. There are no liver targets which are being developed for early disease at this time. For a more advanced disease, in the first couple of months, I think it is a liver-targeted treatment which would benefit the patient, but at the same time, you could bring in alcohol-targeted treatment for a long-term management of these patients. So with that framework, let's go on to the liver-targeted therapies. And I'll switch very fast on some of the general treatment in alcohol-associated cirrhosis. You all know non-selective beta blockers to prevent decompensation in patients with cirrhosis and clinically significant portal hypertension. Rifaximin, some of the controversial data, but this is the best study I could lay my hands on from Danish group showing antifibrotic effect of rifaximin in these patients. Statins, not indicated for cirrhosis or liver use, but if it is indicated for dyslipidemia, they have a hepatoprotective effect. We heard that, especially decreasing the risk of hepatocellular carcinoma. And finally, nutrition, this is the best study, I think an observational study on the left where you see if a patient in the hospital is taking less than 1,000 calories, everybody dies, more than 3,000 calories, everybody survives. And then the coffee drinking, I think there is a lot of observational data that coffee drinking helps these patients in improving their liver disease, prevention of hepatocellular carcinoma and decompensation. And it is a dose-dependent effect of coffee on these outcomes. So now move on to more specific newer therapies which are being developed. Unfortunately, in the field, as you will see on the left-hand side, there is an increasing pool of negative trials in this area. and this pool keeps on increasing, but there is a positive side on the right-hand side. There's some promising agents, mostly targeting regeneration, for example, growth factors, stem cells, interleukin-22, larsucosterol, which is DR928, and fecal matter transplantation. GCSF still remains controversial, hasn't made it to the guidelines for the reason that the data is very heterogeneous, mostly positive studies from Asia, as you will see, and negative studies from the Western world. Currently, there are ongoing trials in the Western world to substantiate whether GCSF really works in this population or not. Stem cells transplantation, I think mostly with the mesenchymal or bone marrow derived, because hepatocyte transplantation is more challenging, the ethical concerns, regulatory issues, and they are more expensive too. This is the study I would like to show, 58 patients, where it showed some improvement in liver function, but did not improve the survival. So maybe a bridge to therapy with liver transplantation. Having said that, the treatment still remains experimental. When I was Googling clinicaltrials.gov, there are 7 studies investigating mesenchymal stem cells in cirrhosis patients from alcohol. 6 of them are in China and Asian areas. Only 1 study is in the Western world. Still an experimental therapy. So interleukin-22. So this is, I think, the phase 1 study done from Mayo Clinic. Patrick was part of it. In 18 patients were studied, 9 with moderate disease, 9 with severe disease. Excellent. You could see the little response here, 83% compared to steroid, which is 56%. And I'm going to show you later how we are going to use interleukin-22 in an ongoing trial starting this year. Larsucosterol, which is just published this week, the data on the phase 2b study showing on about 300 patients. On the left-hand side, you see all comers of severe alcohol-associated hepatitis tend to get benefit with both 30 milligram dose and 90 milligram dose of DR928. No difference between the 2 doses. But interestingly, on the right-hand side, if you see, the data is more statistically significant. If they broke down in US patients and European patients, the data from US patients was statistically significant in favor of larsucosterol. And that led to FDA to award and start the phase 3 trial, which I think is going to be started soon in severe alcohol-associated hepatitis. So let's talk about some of the gene associations, and there are 2 in this JIVA study. You could see there are 2 genes here which are clearly standing out. PNPLA3 is putting you at more risk of developing advanced disease, but there's a protective effect of another gene called HSD17B, and GSK has used that concept to use a small molecule RNA to target HSD17B and cause polymorphisms actually to protect and improve liver disease in these patients. And there are 2 trials going on simultaneously. One is the CTPA, where the MELD is below 12, CTPB, where MELD is between 15 and 21, with more liver stiffness measurement as a primary outcome for CTPA and more MELD change and mortality in decompensated patients. And there are a whole lot of novel therapeutic targets which are being developed. For the sake of time, I will not go into those in detail, but probiotic, which I'll show you some data, not only in liver disease, but also AUD. Digoxin is a good molecule here, which is intensively being studied, and a lot of metabolic targets. And I think it becomes relevant here to discuss metabolic targets with this new nomenclature and MetALD as a new kid on the block. And the metabolic targets are all here. I think we focus mostly on GLP-1 pathway through glucose metabolism. I think Jacob did a great job on going through that, and I'll spend a little bit time on how it impacts the alcohol use and the bile acid metabolism through obeticholic acid, and also some of the FGF pathways, FGF21, and some interesting data. And this is the study I want to show, just presented by Mason at AASLD. We're showing that FGF21 in cirrhotic patients not only safe, but can reverse in about 40% of the patients in the intervention of improving F4 to F3. And then especially if you're not on GLP-1, the effect is even better to 45%, confirming the effect is independent of GLP-1 and not through GLP-1. So let's switch targets now to alcohol use targeted therapies, which I think is most important to improve the long-term outcome. So alcohol use should be applied to everybody, irrespective of what the spectrum of liver disease from alcohol is. Nutrition probably to everybody, drugs maybe to some, and transplantation to very, very few. And I think this is a good cartoon here and a paradigm of treating alcohol-associated liver disease. So this is a trial I want to show from Robert Wong at VA in Stanford. He did a veteran cohort in a retrospective cohort showing how controlling alcohol use can prevent development of cirrhosis in an early A&D. You can see the dose-dependent effect on the risk of cirrhosis and a concept that you can apply to early liver disease patients. And if you control their alcohol use, you can prevent the development of cirrhosis. If you have to use pharmacotherapy, there are 3 pharmacotherapies which are FDA approved. Unfortunately, none of them has been tried in liver disease patients. And of the non-FDA approved therapies in the bottom half, you could see baclofen, gabapentin, topiramate, and varenicline. They have been used as a repurposing of the drugs, if I can use the word, and off-label use of these drugs in treatment of alcohol use disorder. Some interesting molecules coming out. We'll talk about GLP-1. We'll talk about a little bit on FGF21, and aldosterone antagonist spironolactone is also emerging as a molecule for controlling alcohol use. FMT through its gut-brain axis, probiotic LGG, and I think I'll show you the LGG data. These data are from University of Louisville, where I am currently. And this slide shows you the impact of LGG in moderate alcohol-associated hepatitis, improving MELD score, but I think the more glaring data is here on 6 months alcohol use using a simple probiotic LGG. And I think this drug has a potential to treat alcohol use in patients who have cirrhosis of the liver. So talk about MET-ALD, which emerged 2-3 years ago as a new nomenclature mentioned here. So clearly, you might want to use dual therapies or dual agents, which not only impact metabolic effects, but also alcohol use, especially with this new MET-ALD population. So GLP-1, as you know, has mostly cardioprotective and multiple effects to improve the cardiometabolic profile of the individual, but can also decrease alcohol use. And this is the retrospective observational data published in scientific reports on 153 patients. 106 were using GLP-1, 46 were not using, and clearly you can see in blue and green that the AUD or the alcohol use over time decreased in people who were using GLP-1. The randomized control data on GLP-1 is very small. There are, I think, 2 trials. One is positive, one is negative. So still developing more randomized data to substantiate whether GLP-1 can really be used for alcohol use disorder. What about FGF21? More experimental data, and not only the endogenous FGF21, like GLP-1, they have cardiometabolic profile enhancement properties, and exogenously administered in mice can cross the blood-brain barrier and decrease alcohol use, as you see on the right-hand side. So this is a slide I want to show here that whatever you do in treating these patients for alcohol use, it has to be integration of hepatologists and addiction team. For example, on the left-hand side, somebody coming with a non-apparent liver disease, and if you discover they have a high risk of fibrosis, using some of the fibrosis markers, you should integrate with hepatology so that the liver component can be managed. And if you have somebody coming with more apparent liver disease of cirrhosis and alcoholic hepatitis, as you see on the right, and if they have a moderate to severe alcohol use disorder, they should integrate with addiction team to manage both the pathologies at the same time. And this should also happen in designing clinical trials, and I will show you one which are going to start this year, and Patrick will be part of that too, where steroid-eligible severe alcohol-associated hepatitis will be randomized in the hospital to interleukin-22 or steroids, and right before discharge they will be randomized to AU treatment with a camprosate or placebo for 6 months, and then we study the liver as well as the alcohol outcomes at 1 year. So the liver-related outcomes, if you study F3 disease, is more change in liver stiffness. For F4 or compensated cirrhosis, progression to clinically significant portal hypertension, change in MELD score, decompensation, and mortality. And I think you should combine that so that you can study the association of liver and alcohol outcomes with timeline follow back and PET levels. You should also study the metabolic outcomes. And more importantly, I think Ajay alluded to that on patient-reported outcomes. I think all the liver outcomes and alcohol outcomes translate into how the patient feels. So that will be very, very important. And this is, I would summarize here, the last part of my slide is the PYRO framework, which I think Dr. Nipun Verma helped us in writing this beautiful framework on treating alcohol cirrhosis patients, where you have the predisposition targeting genes and metabolic syndrome. You have injury targeting alcohol and infections. You have response targeting some of the inflammation, oxidative stress and regeneration, and finally outcomes with ACLF, organ failure, cirrhosis, and liver transplantation. So, ladies and gentlemen, and chairperson, sir, and experts, here is the summary, take-home messages. The spectrum of the disease is wide and broad. We need strategies to diagnose this disease at an early stage so we can prevent development of cirrhosis. We need liver targets under development with few targets of promise I showed you. And then finally, alcohol use disorder should be targeted to improve long-term outcomes using an integrated or multidisciplinary management approach. And finally, clinical trial design should be integrated with liver and alcohol use targets. And with the new nomenclature, there are certain dual targets available to not only improve metabolism, but also the alcohol use. And I'll stop here, acknowledge my collaborators here, ALCAPNet Work Consortium, my funding, and patients who help us recruitment to these trials. Thank you very much.
Thank you, Dr. Singh. Dr. Singh, you can join us here.
The next session is on pitfalls in diagnosis of TTP and HLH in critically ill liver disease patients by Dr. Dharmesh Kapoor.
So I'll only be touching this. Morning everyone, and thanks for the invite. As you all know, Akash is all things blood, and he was very generous in giving me this rather difficult topic. It could also have been pitfalls in diagnosis of TTP, HLH, DIC and AICSF in critically ill patients. Can't blame him. So this is one entity wherein we are talking of basically the moot concept is consumptive thrombocytopenia. And you're talking this in the context of critically ill patients. You see two pathology slides on the right side of the screen, and these two diagnoses, both TTP and HLH, were actually made from pathology, and then the criteria for their actual diagnosis was laid out. So you see on the right top, these are the cells which have been eaten up, and they are schistocytes. Please remember, they have to be teeth eaten. They should not just be speckled. And in the bottom, you see macrophages which are benign looking, which engulf various components of the bone marrow, leading to the syndrome of HLH. Now, consumptive coagulopathy is actually an umbrella diagnosis. So you have thrombocytopenia at the core. In both of these two entities, thrombocytopenia by far is the most important parameter that you see in hematology. These patients may have organomegaly. They are generally very unwell, and they may or may not have fever. Now, how do you compare this with the rest of the critically ill patients who might be on the ITU? So these patients not necessarily will always have abnormal tests of coagulation at baseline. They may have normal or stable archival data. So it's not as if to say that somebody in whom you are diagnosing HLH as a patient in the ITU, he would be having abnormal coagulation to start off with, hepatosplenomegaly to start off with, features of hypersplenism to start off with, some degree of liver derangement to start off with, and therefore this whole becomes a very difficult exercise in the context of a liver disease patient. And then to top it, there are a number of other competing diagnoses like drugs, infections, renal failure, and the etiology of liver disease, only to name a few. Now quickly, first talking about the TTP. Now we all know that there is a complex interaction in liver disease patients. On one hand, there is a rebalanced hemostasis, and then on the other hand, what really keeps them from not bleeding is the interaction between the von Willebrand factor and the ADAMTS13, which is a protein which actually leads to cleavage of the ultra large VWF multimers. So the conventional wisdom would state that patients who have got advanced cirrhosis, and we all know that ADAMTS13 is synthesized by the Kupffer cells in the liver, they would probably have a very low activity of this protein. And therefore, a subclinical TTP-like state would actually be existing in most of these patients. We also know that a very low ADAMTS13 activity, as is seen in TTP, TTP is actually defined by a level of this activity to be less than 10%, and in some studies 5% or even 1%, is present in many liver disease patients for a substantial length of time. And a typical case in point is the liver transplant surgery. So in the hepatectomy phase, in the N-hepatic phase, you hardly have any of this protein being produced. But then a number of other things are also happening in the background. So therefore, one might think that if you are able to demonstrate the ADAMTS13 deficiency in the setting of a microangiopathic hemolysis, that means you see the abnormal fragmented cells, you see features of hemolysis in the form of an elevated LDH, a drop in hemoglobin, you would probably think that you are dealing with TTP, and therefore you might want to treat these patients. But is that the whole truth? Let us see. Now this is something which is just digressing, because we all know that these proteins, VW antigen activity, the ADAMTS protein activity or its level and its inhibitor are not very easy to assay for day-to-day clinician. So is there a clinical tool which might help us or guide us whether to suspect this condition in a given patient? And for this, there is a very useful score which was given by the Boston group many years ago, more than a decade ago, which is called the plasmic score. Now you see some parameters of the plasmic score on the right side of the slide, but just look at those marked in red. It's not unusual for us to be seeing patients in our outpatient practice who would have a platelet count of less than 30,000, who would have an INR which is nearly the normal range, who would have an indirect bilirubin of more than 2. Now you assign 1 point to each of these parameters. Now what about retics? Again, not unusual. These patients can lose blood in a number of ways, and there might be an enhanced bone marrow activity from time to time. Look at the last two parameters. They might not be there in a given patient, and again that will give you a score. So basically, if you are looking at a cirrhotic patient, and that was my introductory slide, you are not starting from a level play field. Now what happens to somebody who's got high score? So you see this Kaplan-Meier curve, and you might be led into thinking that probably there is an error on the y-axis. That is not true. So if you have got a score of 7 or higher, then there is a chance that you have got TTP, but liver disease patients are not included in this cohort, mind you, and these patients would tend to do much better than those who have got lower plasmic score. So this might be counterintuitive, but the fact remains that TTP has got a definitive treatment, which is in the form of plasma exchange. So therefore, if you have got low scores, that generally happens in the critical care setting due to things like somebody having frank DIC or certain drugs which can produce a microangiopathic hemolytic anemia and certain rheumatological disorders. So that is why you see that the blue and the red Kaplan-Meier curves, which are actually not due to TTP, actually have a lower survival. Now this particular score has been externally validated across countries and continents, has been found to be pretty useful, and therefore it's a good score for us to use in not so sick patients. Mind you, my brief was critically ill patients, so this is not a cohort that I would be using this score in. Now again, there is a very interesting correlation between WDF activity, ADAMTS, and the endotoxin, which is highly circulating in critically ill patients. So this study, which recently came from Japan, talks about the various parameters as you see in table. So as the liver disease advances, it's intuitive to believe that the ADAMTS13 level comes down, VWF antigen levels go up, the ratio again gets reversed in favor of WBF antigen to ADAMTS being higher, and then the inhibitor also goes up, which leads you into believing something that we never talk about, that this might be actually an immune phenomena. So this might be an immune TTP, and therefore when we use plasma exchange, we are wondering that we are only removing the large multimers, but it might also be that you are removing the inhibitor. And these box plots show you exactly the same thing. So if the endotoxin levels go up, the inhibitor levels go up, and therefore this activity can actually be low even though the actual antigen might not be low. So this is very, very intuitive, and most of our patients in the ITU will be having high endotoxin levels. So this whole plot is still not completely sorted out. So therefore, when we talk about a low ADAM-TS13 activity in liver disease, is it TTP or something else? And this study came only in an abstract from the Mayo Clinic, wherein a very small cohort, whenever they found that there were patients who were having a low activity and they were treated with Plex, which seems to be a very low hanging fruit for us hepatologists, what were the outcomes? It was seen that in the general ICU setting, the differential diagnosis for a TTP, like I said, would be liver dysfunction, DIC, and TMA of other causes. And those other causes could be anything. It could be sepsis, it could be accelerated hypertension, it could be a pregnant lady with HELP or preeclampsia, it could be a solid organ transplant, it could be somebody with a malignancy, and some rheumatological disorders. So those are the differential diagnoses for a TTP in the context of a non-liver patient. However, even though this cohort was a TTP cohort, but most of these patients, more than 90% of them, had an ISTH DISQ score of greater than 5, which tells you that this is not a homogeneous cohort. And those who were treated with Plex, they showed initial improvement, but the moment the Plex was discontinued, they again continued to deteriorate because the underlying liver disease was still there. And the 6-month mortality in this cohort of patient remains extraordinarily high. So I think there has to be a kind of a rider to using Plex just based on the antigen assays and the inhibitor activity. Now, this is management is not to be discussed, so maybe it will come up as questions. Now, quickly switching gears to HLH. So we all know that this is a hyperinflammatory disorder. Again, this is something that the IC physicians rejoice in diagnosing. This is again a clinico-pathologic setting, like I said, that even for TTP and for HLH, you don't need to have schistocytes right at the outset or hemophagocytosis right at the outset to be making this diagnosis. So even though the pathological for the foundations were laid down before the criteria were given, but still these two are not needed to diagnose TTP and HLH respectively. You could either have a primary HLH, which has got very strong genetic underpinnings, or you could have secondary LHH, which is going to be the topic for my talk. And in this, it's very, very important to remember that liver dysfunction / failure can itself produce a syndrome of HLH, but you have to look at the other triggers. Now, all of us must get familiar with these two criteria. Now, please remember that the HLH 2004, and there is a Histiocyte Society which exists out there in the world, it has laid down these criteria. You need to have organomegaly, fever, cytopenias, and hypertriglyceridemia, hypofibrinologemia, and most importantly, hyperferritinemia. The last two things are extremely difficult to do, which is the NK cell activity and measuring the IL-2 receptor levels, which are very, very difficult for most of us to procure. But please remember, this was laid down in the pediatric population. It was an expert opinion, and it has been validated only in that population, even though we use it erroneously in the adult population also. For somebody to be diagnosed with HLH by the HLH 2004 criteria, they need to fulfill 5 of these things. And then there is a HEP score which was given later on in the adult population, but not necessarily the critically ill population. And there you can see that there has been due weightage given to the liver dysfunction also. Otherwise, most of the factors remain the same. And the most recent iteration on this particular subject is by the European League Against Rheumatism and the ACR criteria, which were laid down in 2022, which have recognized the CNS dysfunction and the hematological role in this particular situation. So how do we diagnose it by the bedside? It's a sick patient, generally febrile. Fever has been there for a good number of days or even weeks. They might be having sepsis, septic shock. They might be having MOF. We all hope that they do not lead to the stage of MOF when we make this diagnosis, because otherwise the treatment options are very few and far between. The most important thing is hyperferritinemia. So all of us can diagnose that. Please remember, in the initial criteria, it's only 500, but that is only in the pediatric age group. For adults, it's much, much higher, maybe 6 to 10 times higher. And hypercytokinemia, which is again not very easy for all of us to assay in the lab. And they will have some other diagnostic criteria, including organomegaly. And if there is a pathological feature of hemophagocytosis, that leads you to this diagnosis. This is an excellent study which came from Berlin over a long period of time. Now, mind you, these are not liver disease patients. This is an unselected ICU cohort. The baseline was all of these patients had a ferritin level of more than 500 mg per liter. And when they found this whole cohort, which was close to 2,600 patients, only 50 of them were assumed to be having HLH. And when the experts sat down, this number was reduced from 50 to 40. So please see hyperferritemic patients who fulfill the criteria of HLH, they do much worse. And that is what the circles are telling you. So most of these patients had either sepsis or they had septic shock or they were on extracorporeal support. And as you see at the bottom of the slide, they also had a much higher mortality level. And they found, these authors found, that you get a very good C statistic value even if you have 4 and not 5 of the criteria laid down. And if your H score was only 168 and not 190, which was the original H score defined in the non-critically ill patients. But mind you, these bar diagrams tell you that most of the times when we see our patients in the ITU, they actually do not have they do not fulfill the HLH 2004 criteria and they do not have a very high H score also. Now, what about transplantation? Like I said, many of these patients would have very serious kind of a liver dysfunction / failure. The general wisdom is that liver transplantation is actually contraindicated in this cohort of patients. Very few studies. And why so? Because it has got strong genetic underpinnings. So even when the syndrome occurs in adults, we feel that they have got a kind of a muted response to the proteins which lead to a kind of a malfunction of the NK cells and the cytotoxic T cells. So therefore, those genetic underpinnings stay, and even though they have been diagnosed as adults and not in the pediatric age group, they probably still are extremely hyperinflammatory and hypercytokinic. So this is a study which came from Toronto, from the Sick Children's Hospital. You can see that hemophagocytosis, like I alluded to earlier, is not present in all of them. It's picked up more on EM than on light microscopy, but biopsies were not done to demonstrate hemophagocytosis. It was only to find out the etiology of the liver disease. And this was extremely challenging. A patient's course that you see over here who underwent a retransplant, and then another one who underwent transplant followed by a bone marrow transplant, and a host of other drugs with which we have got very little experience were also used. How do you manage this condition? This is the typical protocol, and this is the ULR ACR guidance on therapy, which is more nuanced and which actually takes into the consideration the etiology of the HLH syndrome. So the practice points, ladies and gentlemen, are that in day-to-day critical care hepatology, these two conditions are less likely to be actionable by us hepatologists. The competing diagnoses are invariably there, and therefore in a critically ill patient, you might not be able to make this diagnosis. When does this one suspect this? So what is the reason for Akash giving this talk? A stable cirrhotic who suddenly drops his platelet count and the INR and APTT remains good, fibrinogen remains good, FDPs remain good, and he has got an abnormal neurology which you cannot explain in any other way by the usual things that you use. This is a patient in whom you might want to look at the peripheral smear, might want to send the VWF antigen, ADAM-TS activity, so on and so forth. HLH, yes, we must diagnose that. So as a routine now on our unit, even when somebody presents with ALF, acute liver failure, we always try to send the parameters for HLH, because we think that this particular patient, even if you transplant him, might not have a very stable course and might lead to a lot of trouble. The other importance of diagnosing HLH is a very complex interaction that exists between this syndrome and the EBV virus. So this is a question which oftentimes intrigues me, that why do we hepatologists only talk of bacterial infections and fungal infections? So what happens to viruses in these immune compromised hosts? And again, that is a very interesting interaction. And lastly, with most of us using the immune checkpoint inhibitors as well as the CAR T cell therapies, we oftentimes get consult in hepatology for patients who have the cytokine release syndrome. It's useful to know this syndrome. But if you want to think that, yes, I have diagnosed HLH and I would be brave enough to transplant this patient, I think it's a Herculean task. Have I done it? Yes. Was the experience good? Very forgettable and regrettable. Thank you for your attention, and I'll be very happy to take any questions.
Thank you, Dr. Dharmesh. Please join us here. The floor is open for questions and comments. Dr. Akash, that video is scheduled now or later?
You can ask 5 minutes for question and answer right now.
Third presentation.
We don't have the third presentation. The Professor Mark Mutai actually missed his flight yesterday.
Oh.
So he could not come here. So we are getting his pre-recorded talk that we'll play during the lunchtime.
The stage is open for if questions any.
So my question to Dharmesh sir, a very excellent talk as usual. I would just like to hear your views about, sir, post liver transplant TMA. Is hemolysis, TTP, all a same spectrum, and how do we use plex and the parameters to gauge response to plex, sir?
So I think the TMA post-transplant, and I mentioned that in the differential diagnosis, generally has been attributed to the CNIs, though like I said, it could be happening to a number of other reasons also, including sepsis. And if you have been able to conclusively rule out and it was a stable surgery and not a very sick patient, and you start to see features of MAHA with classic smear, then you would probably end up implicating CNIs. Take the tacrolimus. Literature tells you that it's more common with tacrolimus than cyclosporin, though I would not believe that completely. And you could give a trial of plasma exchange in this cohort of patients. So that is something which has been reported in literature. In transplant circles, this gets discussed more often than not, but almost always when such a question has been discussed with me, one has been able to find a confounder. In fact, to tell you the truth, many of these patients end up losing the graft because their CNIs have been stopped altogether. Okay.
So thank you for the question. Hope you all enjoyed the session so far.
Akash, no questions from your side?
We're actually still around 5 minutes behind schedule. So
just if we have the interest of time, we oftentimes keep talking about, and I hear discharge summary from numerous centers that we made corrections which were tech-based and Rotem based. So I think this is a very good gathering with all experts, and Dr. Kamath is here. So in patients who come to the liver intensive care and who do not have hematology as the main reason why they come to the ICU, do you think this is a tool worth pursuing, that we correct their coagulation based on the tech results and Rotem?
well, the Patrick, and I think we also have the other Patrick Northup. We would want him also to comment on.
Yes, absolutely.
So,
hi. There's a talk today at 3:15 and another at 5:15 about this issue exactly. I think it's difficult to interpret Rotem or TEG in the setting of critical illness, especially in decompensated liver disease, acute on chronic liver failure as well. So it's a very difficult question. I tend to not preemptively correct coagulation disorders, but in the setting of bleeding, I think platelets and perhaps low volume factor replacement is useful.
So if a patient is in ICU long enough, getting into weeks, you are going to see these problems. And at that stage, it becomes much more difficult to make a diagnosis. So the paper that you quoted from Mayo, Meeraj Sridharan's in 2023, be a little careful about the conclusions there. It was a retrospective study. There were 70 patients, wide variety of liver diseases. Some were post-transplant, some were alcohol-related. Among them, not everyone had ADAMTS13 checked. So in the very selected patients whom they found it, level below 10, I think, that was the level they took, they benefited. Whether that applies to every patient, I don't know. So to me, it's just a hypothesis testing. Consider this. I like plasma exchange when you're running out of options, but I think there's a question then exactly whom you selected, what are the criteria? I don't think we know that as yet.
questions. So I think we wind up the session. Thank you, everyone. Thank you very much.
Thank you, speakers, chairpersons, and our experts. We'll have a short tea break. So I request everyone to be back by 11:25. Thank you.